appropriate for an active surveillance approach. So basically, when we think about this, the first thing that always comes to my mind, maybe before I had done this research, was size. So the thought is that, first of all, asymptomatic nodules and small. So the thought was less than 1 centimeter, or now up to less than 1.5 centimeter, confined to the thyroid and surrounded by normal thyroid tissue, are acceptable for for management with active surveillance. And this applies to with or without confirming the actual cytopathology of the nodule in people who want to avoid surgery. So this is people with who are resistant to the surgery, who are medically with comorbidities not appropriate for surgery, and who really or people who are not interested in potentially having to take long-term levothyroxine replacement. That is, people who want an intact thyroid. And so conversely, what tumors are not appropriate for an active surveillance approach? So people whose tumors are, number one, larger, so larger than 1.5 or even 2 centimeters, and then tumors in this subcapsular location near important structures. So tumors that abut the trachea, tumors that are in the path of the recurrent laryngeal nerve, or tumors that are growing quickly. So if they are doubling in size in less than 2 years, they're considered inappropriate for observation, and a more aggressive strategy is warranted. And so why did we focus on recurrent laryngeal nerve invasion? Well, so it's, essentially considered by the American Joint Commission on Cancer and the TNM staging system to be a negative prognostic factor. It's also associated with an irreversible effect. So typically, once the vocal cord or once the recurrent laryngeal nerve is damaged, this isn't a fixable problem intraoperatively or otherwise normally. I'm sure our surgical discussant can add to this at a later point, but this is an irreversible problem.